only billing because this is actually a joint presentation. Both Jack Nanskivell and I are members of the board of directors of the hospital foundation, and so we're both here to talk about our new fundraising campaign that we're very excited about. And it's going to be rolling out over the next few months and year, but this is the very first presentation that we've done. So it's a world first for Kincardine Probus. And I'm going to do the boring part. I'm going to talk about some of the background. And then Jack's going to come in. He's going to save the entire presentation because he's going to talk about the hospital redevelopment. That's really the impetus for our fundraising campaign. And then he's going to talk about our fundraising goal. So at this point, I understand that I can share the screen. So I'm going to do that. Just bear with me because we got a slide presentation. And get rid of that. Okay, so hopefully people can see this. Just a bit of a history lesson. The Kincardine Hospital began in 1908, and that's when some local people got together, formed a non-profit corporation, called it the Kincardine General Hospital, and its office were to establish and carry on a general hospital. And then the land that is the site of our present hospital was donated by Madame Josephine Gualco to this new corporation. And Probus golfers may be familiar with that name because she was also the lady that introduced golf to Kincardine. And that's why there's a bronze plaque dedicated to her on number 1 tee at the golf course. And the hospital has been running since 1908 or maybe 1909. It's been a public hospital ever since. One change in the name took place in 1965, and that's when the words "and district" were added to the name. The foundation is much more recent. It started in 1995, and that's when the hospital, Kincardine District General Hospital, decided to incorporate another corporation, called it the Kincardine District General Hospital Foundation, and its objects were basically fundraising, to raise the money and spend them on for the benefit of the hospital. So a couple of notes about this. The foundation was set up to be completely independent of Kincardine District General Hospital. Each one had its own board of directors, neither one had any control over the other. And the second thing is that obviously they're very different roles. One was to operate and manage the hospital, and the other was to do the fundraising. And it's not unusual for hospitals to have foundations. In fact, you'll be hard-pressed to find a hospital anywhere in Ontario that doesn't have a separate foundation. So a couple of notes about this. First of all, why do hospitals have to fundraise in the first place? Don't we have a public, Medicare system? Doesn't the government pay everything? And the answer is no. And just a few notes about how provinces fund hospitals. They do provide hospital with really substantial operating funds, but it's not always enough to cover the programs and the services that the hospital wishes to run. And the second thing here is a really big one. The province does not fund the purchase of medical equipment. You want medical equipment for your hospital, the community has to come through. And the third thing is that for capital projects, like the redevelopment that we're going to talk about, the province does provide the capital funding. But even if you get that, there's still a local share that we have to raise. And Jack will go into that in much more detail. So another question is, why do hospitals have foundations to look after the fundraising? And the answer, there are two basic answers. One is simply to spread the workload. Anybody that's on the hospital board of directors can tell you how time-consuming it is, how much effort they have to put into that. And at the same time, fundraising is becoming more and more important. So the theory is, why not split the two and have the hospital concentrate its energy on managing the hospital and let the foundation board concentrate on the fundraising. And the second reason is that it's got there to protect donations from being scooped by the Ministry of Health. And the idea here is, and this is a fear that really never materialized, but the fear is, what if you got a really successful hospital? They're really successful at fundraising, and maybe they got $1 million more in the bank account than they had the previous year. When the ministry figures out how much operational funding to give that hospital, will they say, wait, this hospital doesn't need it as much as they did last year, we'll cut back the operational fundraising, or operational funding rather. And it says never happened, but there's always that fear. And so the idea is to keep the money in a third party, a separate corporation, out of the clutches of, potentially at least, of the Ministry of Health. So now more history. 1998 was an important year. That was the year that Kincardine District General Hospital, the corporation, amalgamated with the corporations of the Walkerton, Durham, and Chesley hospitals to form South Bruce Grey Health Centre. So it now owns all the assets that the Kincardine District General Hospital used to own, and it is now responsible for managing the hospital, and of course the other 3 hospitals too. At the same time, the foundation made 2 changes to its letters patent. One was to make it clear that any funds that we receive benefit only the Kincardine Hospital, not the other 3 hospitals. And the other was to change their name, and the name is now Kincardine and Community Healthcare Foundation. And so what have we been doing over the last number of years? This is some of the equipment that we purchased in the past decade. And you'll see all sorts of things, from x-ray equipment to beds, to bed pans. It's quite a substantial list. And in addition to what we spent, which is like about $3 million during that time, we've also committed, last year we committed about another almost $1 million of spending. And then we've got the spending that we're looking at just to keep the equipment up at the hospital, and that's going to be about another $1 million over the next 3 years. And then there's the CT machine, which Jack will talk about, and that's another $2.7 million. So those are all commitments that we've got, and then on top of that, the redevelopment that Jack will elaborate on soon. And also it's important to note just how much the Kincardine Auxiliary has done. They do an amazing job. We've seen almost $270,000 in those years, those 10 years. So one thing we should be very proud of is that Provis is well represented on both boards. Bill Heikela is a director, and a few weeks or months or so ago he became the board chair. And then Jim Bagshaw and Doug Harris are also directors. And on the foundation, I already mentioned that Jack and I are directors. And I have to mention Greg here because Greg is a former director. He's still an active member. And he was the president for quite a few years. And I am told, I wasn't on the board then, but I am told he really brought us into the 21st century when it came to fundraising. And then Jim Bagshaw, before he went over to the other side, he was also on our board. And I mentioned Newt Cato here too. Newt may have been on the very first board. If not, he was on one of the very early boards. And then now next thing I'm going to do is introduce we have a new, because of this fundraising campaign, we have a brand new capital campaign committee. And so just to show you who they are, and you can see there at the top of the list is Murray Elston. And we're as excited to have him as he is excited to be on the committee. And we really thank him for being part of it. And you can see some of the other names here, Dr. Jason Murray, Catherine Freemanis, Brad Kirkconnell, Bart Fisher, Dominic Celeste, Bard McKay, Sasha Siegel, and then Jack and Carol Collins and I are on the board. So we're the board representatives on the capital campaign committee. And by the way, we are always looking for more volunteers. We really want to expand the circle here. We have subcommittees, and so if anybody's interested, there's the opportunity to put your name forward, and we'd be really happy. The more volunteers, the better. So now I'm going to get to the heart of the matter here, and first thing is to this diagram of what our hospital looks like today. And whoops, went back. Bear with me. The original house that was the hospital for the first 40 or 50 years is gone basically now, and I don't know if you can see my cursor there, but over on the west side of the property, the left-hand side, and it was built right on the bank of the hill. So there's never any room to expand the hospital west. So all the additions to it are south and east and north. And so you can see what they are. In 1956, that area in purple, and then the operating room in 1959, then the large inpatient unit, the yellow, in 1966. And in 1980, the diagnostic imaging, the lab, the food services, where they are now, that area was built, and emergency. And then in 1987 and 1988, very significant addition. The area in orange was actually originally supposed to be chronic care, and the area in yellow was supposed to be acute. And I think, it obviously took a huge portion of the hospital at that time. And then there was a 1988 addition, light blue, and then a very small addition in 1991, sort of a lime colored thing, and then some remedial work in 2004. So the question is really, what's wrong with this picture? And just a couple of general comments. First of all, the fact that there hasn't been any major addition to the hospital in 34 years, and lots has changed in 34 years. Secondly, the focus on inpatient care. And back at one time, we don't know for sure the exact number, but it's something like 67 beds were supposed to be in our hospital. We're now down, we're accredited now for 17. And so things have really changed. Patients spend a lot less time in hospital for many reasons. 3 of them being medical advances that allow people to recover more quickly from surgery. And in fact, many surgeries and many procedures can be performed on an outpatient basis now. And also, at least in theory, we have more home care services so that patients can recover at home rather than in the hospital. But as the need for hospital beds has decreased, other services have really expanded. They're becoming increasingly important, in particular, the emergency department, the diagnostic imaging, lab services, and ambulatory care. And they kind of feed on one another. It's the emergency department. Everybody's been in emergency over the last few years will know just how busy it can be. It results in more lab work and more diagnostic tests. The same thing with ambulatory care. Again, more lab tests, more diagnostic imaging. Another thing about this picture is that the 1956 and 1959 wings are basically at the end of life. They're actually recommended for demolition. And even the 1966 edition, a big yellow one there, it's old, it's got inflexible construction, there are hazardous substances in it, and it's been recommended that no more capital funding be invested in that wing either. Another factor here is we're about to experience a major population boom. The Bruce Power major component replacement project is going to add somewhere close to 6,000 people to the area served by our hospital, and that's within a relatively short period of time. So these are new workers that Bruce Power hires, new workers that their subcontractors bring in, workers employed in spin-off service and retail industries, and their family members. And it's going to make a huge change to the services that the hospital is going to have to provide. And more specifically, some of the shortcomings. The big one is space. And you can't overemphasize it, even though I tried. And all services, emergency, diagnostic imaging, lab services, ambulatory care. They need space now, and the problem's only going to get worse as our population grows. The CT scanner, you're probably aware that we're on the verge of getting one. However, there's absolutely no room in our present hospital for it. Third thing is the decontamination. And our hospital is Bruce Power's primary emergency decontamination site. They have to have one, and we're it. And there is one now, but it desperately needs to be enlarged in order to comply with today's standards. Then you can go through a whole host of infrastructure issues, and including, the ventilation system. Air changes are particularly important in COVID times, and in many places in the hospital it's inadequate, very inadequate. The sprinkler system, only a small portion of the hospital is sprinkled now, and it's going to be mandatory that the entire building be sprinkled within the next few years. The chiller, the main one has been updated, but the backup chiller uses refrigerant that's dated, and in fact you have to get rid of it within the next few years. Then you've got the fire alarm, the wiring, the roof, the security system. All of those are basically at end of life. And the lighting is old and energy efficient. It needs to be changed out. And then there's the layout of the hospital. It was built for other times, and it just doesn't work with the services that we now need to emphasize. And just a few little examples. The location of the emergency department. It's very close to public hallways, and that leads to serious privacy concerns. Also, the emergency department doesn't have its own outside entrance, and so anybody who's in the hospital knows just how crowded it gets in the entrance. Most hospitals today have very separate emergency entrances for walk-in patients, not just for the ambulances, but a second entrance just for walk-ins. And another one is the lab. It's located at a very fairly large distance from the entrance. The logic is to put it closer to the entrance where outpatients can access it more easily. And so there are a ton of more of those. Those are just three examples. And then there's telehealth, and it's becoming increasingly important because we have a thing called the Ontario Telehealth Network, which gives access to specialists when they don't, when it doesn't maybe make sense to bring them to on site, or maybe the nature of the consultation doesn't even require a physical examination. But our patient exam, treatment, and testing spaces within the hospital lack telehealth capability. And the last one I've got on here before I turn it over to Jack is the loading dock, which may seem like a really small thing, but it really isn't. It's actually very important, particularly these days with infection control that has to be carried out. And it's our loading dock right now. It's way too small, and it's also uncovered. And so I'm going to turn it over now to Jack. Hopefully, Jack, you're ready, and just tell me when you want me to click the slides.
Okay, thank you, Graham. Before I begin, I should acknowledge the fact that Clark Pollock is also a former director of the foundation. Graham, if you show the next slide, it will demonstrate the magnitude of the redevelopment. And it's just a little bit difficult to look on here, but virtually the front end of the hospital will virtually double in size as a consequence of the redevelopment. Next slide there, Graham, I'm afraid we can't see too much of that, but the next slide maybe show a bit more definitive, the expanded area. This shows you the area that the emergency area is in pink, and it will virtually triple in size. The medical diagnostics and imaging, it will probably triple in size as well. And then you see the laboratory services, which doubles in size, And of course, the front lobby and associated rooms with it will almost grow by 5 times. And so you also see a little bit of a light blue area where that's the back of the house, and that's the loading dock area, which will double in size that Graham was looking at. Do you want to give the next slide there, Graham? This shows you what I was just talking about, that the emergency room is going from 3574 up to 11,300. Just to give you some idea of the difficulties we've had this past summer, our physicians treated 60 patients in one day in our emergency room. That's a huge number and vastly is over the capacity of our local hospital. Diagnostic imaging, of course, as you can see, it will grow from 2,400 to 7,400. Laboratory will more than double. And as I said, front of the house, which actually includes the decontamination area that's aligned with Bruce Power. By the way, that is growing from 1 to accommodate 2 people. And so it's a substantial difference in growth of that area. And then the back of the house will grow as well. Now, in the front of house, which will also include the lobby area, that expands dramatically for a waiting room that will allow patients not to be in the area where other patients from inpatient and so forth are being transferred into diagnostics as well as through the emergency room. It also includes a conference room as well. Can you go on to the next slide there, Graham? This slide shows, if you can see that blue area, it shows you where the CT addition is going to happen. And the light blue is the area for redevelopment around the diagnostics area. And you can see how much square footage is added to the diagnostics area by that blue area. So you can see how it has grown significantly. As I said before, it has virtually tripled. And then you can see to the right the overall picture of how the hospital will be developed. Would you go to the next slide, Graham? You got the next slide there? Because I want to share with you, oh yes, this is the emergency room, and it shows you what is happening there. There are 13 treatment spaces for acute treatment, and we also see and treat areas, 2 isolation rooms or anti-rooms. There's a flexibility, of course, in space use, but basically the expanded decontamination zone is a significant portion of this new development. There will also be a canopy garage area that is a little bit to the south of the shown area to receive ambulances. The ambulances will come in and transfer patients in at the south end and not through the main entrance as it is at the moment. Next slide, Graham. Just to share with you a bit about the stages that we go through to get the capital improvement by the Ministry of Health and Long-Term Care to approve a hospital redevelopment such as we have. And it's the same process that we're using to get the CT building as well. Now, when we look at this, first of all, you start off with a pre-capital proposal by the hospital to request a capital improvement. And then you move into stage 1. Stage 1 is a reasonably detailed proposal to the ministry to establish the size of the new building. For example, it's sort of what I would call formula kind of process, in the fact that you establish the patient traffic through your hospital. You have a ministry standard which dictates how many square feet you must allow per patient, and you multiply that, and then you go to a formula kind of costing. That formula costing can take you anywhere from $1,400 per square foot to $1,700 per square foot. Now, in a conference area, you do not require the same kind of air changes per hour. It could be ranging around 6, and you do not require oxygen outlets or as many electrical outlets. So that costing would be around $1,400 a square foot. But as you move into the emergency room where you require all those services, and particularly up to at least 10 air changes an hour, you're looking at around $1,700 a square foot. So that gives you the basis of where that first stage 1 proposal goes with costing. And the costing plus or minus 10% or 20%. Then you move along after that's approved into stage 2. Stage 2 is defining the project and giving more definition to the actual use of space. And that is a very critical area for approval by the ministry, because it also takes the costing down to a plus or minus 15%. And then subsequent to that, you go into stage 3 and 4, and 3 and 4 is basically a definitive design of the area of the hospital you're renovating or redeveloping, or in the case of the CT building, it's the new building. So that is a more refined costing with a plus or minus, hopefully, at 10%. And once stage 3 and 4 is approved, then you are moving into stage 5, where you tender the project to the construction people, and you proceed to put a shovel on the ground. Next slide, Graham. This basically is what I've just reviewed with you, but to give you an example at the bottom there, saying the CT scanner building is in stages 3 and 4, and we anticipate approval of that building by the Ministry of Health and Long-Term Care anytime. And it's immediately afterwards, we've already done the pre-qualifying bids, and so that we're already with the tenders to go out, and hopefully that shovel will hit the ground in November of this year. We are unfortunately a little bit behind with the proposal for redevelopment. It is still in stage 2, and there has been a lot of controversy with stage 2 as the redevelopment of the front end of the hospital, because the ministry has been concerned with also what's happening in the inpatient area and the new standards set for washrooms, air quality, and so forth. COVID-19 has brought a whole new set of circumstances to hospitals where they're having to very seriously examine air quality. And so this has been holding us up a little bit on stage 2. Next slide, Graham. The CT scanner project, as you know, has been approved by the ministry essentially, except now we're in the approval process for the building itself. And we as a foundation have committed $2.7 million towards that purchase of the CT unit. That includes the costing of the CT, which has been placed, and the anticipated delivery of the CT machine itself is in early 2022. But that costing is $1.425 million. We also will be paying, or have paid, for the revamp of the entrance area, as well as our portion of the building that we are required as a part of the local share to pay. Next slide, Graham. This is the redevelopment costing. The total cost of redevelopment is nearly $66 million. Although the Ministry of Health and Long-Term Care is a primary source of funding, and Graham already alluded to, the fact is that we as a host community are required to pay for what they determine is the local share. The local share consists of 10% of the building costs, that's the bricks and mortar basically, 100% of components that include any kind of retail space we might have, like if we ever put a Tim Hortons into the hospital, parking, a foundation office, the auxiliary gift shop, and any space that is non-medical. Basically, that non-medical would not be funded by the ministry. 100% of cost of all new and replacement furniture, computers, medical equipment. 100% of any new equipment purchased by the hospital, including commissioning, and the relocation of any existing equipment and the commissioning, so that you see that the proportion in the redevelopment is assigned to the local share is much higher than it would be normally if we were just building a new hospital. The local share cost of this redevelopment is 10.14 basically million, and of course the Ministry of Health and Long-Term Care will pay 90% of the building costs, and they also pay all of the planning and design costs. So their total portion to be paid by the ministry for this redevelopment is 55.6 million. Grant, next slide. Just to give you an idea of the impact of replacement equipment to your hospital foundation, which as well as the what is coming up in terms of the redevelopment and the CT, you'll see what we've currently have committed to in 2021, 2022. And you can see the list of equipment, and that includes the CT scanner for 2.7. But our total, and there is two, by the way, you'll notice two ultrasound machines in here. One has greater capabilities than the other, and it's just been recently installed and being used now. But our total commitment through these 2 years is 3.714 million. Next slide, Grant. And if you look at this, that we've now got 3.714 as our capital commitment to South Bruce Grey during 2022 to 2021-22. We also have in the 2022 to 2025 a further commitment of over $1 million, and a good portion of that, I believe it's around 900,000, is to replace the mammography unit. And if you recall, the mammography unit was replaced or purchased and replaced in 2013, so that you can see that new equipment is historically had to be replaced between 7 and 10 years. The advancements of technology have been horrendous, and it obsoletes the equipment so that sometimes we're caught with equipment that you no longer can have servicing. So it's very, very important that we, as a foundation, carry a significant amount in our investment funds to cover these replacement costs. You can see the redevelopment is 10.139 million, and you can see that we are carrying a very heavy contingency fund, and that's $5 million. And I will address that in a few minutes of why that fund has to be in that order of magnitude. But our total funds needed from now to 2025 is around $20 million. We presently have in our investment portfolio 11.2 million, and so we have rounded off our fund raising target to support primarily the redevelopment at $10 million. And you can see down at the graph at the bottom how everything is spiked, caused by the CT and CT building as well as the redevelopment. And I might comment on this because there is a significant rationale behind that $5 million. I've already pointed out to you that about the cost per square foot, and the fact is that COVID has caused a great deal of uncertainties within the construction industry, primarily because of material costs and also the lack of labor. And so it is a very difficult situation to address for us right now. We could be looking upwards of a significant increase in our estimated cost of the CT building and as well as the redevelopment building. The thing is that we have also other major equipment that will require being replaced over the next few years, such as the new X-ray machine. It was installed about 4 or 5 years ago, and so we anticipate that by 2025 we will have to replace that machine as well. We also start to see that our request from South Bruce Grey can vary between $100,000 a year to $1 million a year. And we have no way of anticipating that for certain because things can happen relative to equipment becoming obsoleted in the previous year. The big thing is that we feel that the target of 10 million is a conservative target. We probably should be anticipating that Phase 1 redevelopment local share could even grow because of the uncertainties in the marketplace to $12 million. But nevertheless, we are striking our campaign off based on the $10 million. Now, just to give you an appreciation, in our community, we feel that certainly that $5 million is warranted, because I would suggest, in my 15 years of having been on the foundation, that that we should have no less of a reserve in our foundation funding than $2.5 to $3 million to accommodate the unexpected from the South Bruce Grade. But also, in going forward with our campaign, you will see earlier the number of good and wonderful people who have stepped forward to help us with the campaign. We will have in place, of course, on the major wall going in the entranceway of the hospital, a significant area devoted entirely to donations from members of the community and our major stakeholders in recognition of those major donations. I hope that every one of you will join with me in considering a significant donation to our new redeveloped hospital, because this is a great opportunity for all of us to leave our footprint in a very visible place within our community on the entrance to our hospital. So that ends my portion. Graham, do you want to wrap it up with anything you have to say?
Oh, I'm fine. Any questions that anybody has? I've got